Let's turn now to the presentation of Helmut, and let's take a look at the situation of a patient, or how a patient presents in our institution with the disease. So Helmut, maybe I can just hand it over to you.
Yeah, Thomas, thank you very much. I was asked to give you a very brief introduction on imaging in COVID in general, and I will walk you through two typical cases. Before that, just to remind you, chest radiographs are not the way to go. The sensitivity of chest radiographs is very low, very limited, and even more so the specificity. So if you are in doubt if a patient has a COVID-19 infection, maybe you have no access to RT-PCR, you should go to CT and not chest radiographs. So let's walk through this case. This is a patient from last week, actually, a patient who came in with chest pain, and she had also a low lymphocyte count. However, she was not suspected to have a COVID-19 infection, so she went to our CT scanner. And what you see here are very typical findings here. You see, this is normal lung parenchyma. See these dark areas, this is normal lung parenchyma. And you see, not better here on the left side than on the right side, an increase in lung density. As you still see vessels here, that's what we call in radiology ground glass. So whenever you read in literature ground glass opacity, that's what it is. You see an increase in density with a preserved visibility of vessels. And also then up here, you see that it becomes a little bit more dense. And what is striking, that these findings are more pronounced in the lung periphery. And if you look here at this sagittal formation, you see it's also more pronounced in the dorsal parts of the lung. So this is a very suggestive case for this particular disease. However, although it's very characteristic, it's not specific. However, you have to see these diseases in the clinical context, and this is in a situation in which we are in the beginning of an epidemic or pandemic here in Austria. So we suspected this disease, and this was then confirmed in RT-PCR. So we have to be aware that patients might come to you as a radiologist and there's no suspicion of this disease, and you have to come up with the suspicion. That's another patient, just two patients, just to briefly show you what to look for. A patient who is immunosuppressed, and he came in despite his doctors told him to stay at home. And he got scanned then already with a suspicion of a COVID disease, and you see here again, and now you know how it looks like, that's ground glass. But in contrast to what I showed you before, it's not that much in the periphery, it's more rounded, and also here, more rounded ground glass, not as band-like as in the case before. And that's another pretty characteristic manifestation of this disease. However, as mentioned before, this is not specific, and the diagnosis cannot be based on imaging alone. You see here the distribution of these rounded ground glass areas. So imaging plays a role in COVID-19. However, CDC does not recommend the chest radiographs or CT to diagnose COVID. So CDC is the Centers for Disease Control and Prevention in the US. They do not recommend to do that for many reasons. One is that, again, although characteristics, these findings are not specific. And if you are sending a patient to the radiology ward, you have to transport a patient throughout your hospital, and you then probably expose other patients and also run into the risk of exposing personnel. So if possible, avoid CT scan unless you have suspicions of superinfections, complications, or whatsoever. However, in cases in which your RT-PCR gets saturated, meaning you do not have enough tests, then CT is the way to go. It's not chest radiographs. One thing which is striking, that RT-PCR is not a perfect test. It's a very good test. However, the sensitivities, the reported sensitivities vary quite a lot. In China, we have reports of a sensitivity as low as 60%. In other countries, it's somewhat better, up to 95%, but it also depends on how you get the swabs. So it's not a perfect test, but it is the test to diagnose COVID-19. However, again, nothing is perfect. Sometimes the RT-PCR is negative initially, and you already see findings on the CT scan, so this may happen. So what you see on a CT scan typically are peripheral, focal, or multifocal ground glass opacities, as I just showed you, which affect both lungs. Sometimes you see also consolidations, and then over time you see more extensive findings, and we will see later a case showing that as well. So these are the initial findings we are looking for in these patients. And very important here is that we only rarely observe these findings in COVID-19: pleural effusions, lymphadenopathy, or cavities, as well as micronodules, as you see here in these patients, or tree and dot. So this is these branching structures you see here. All these findings are something you do not expect to see in COVID-19, and if you see that, then you have to suspect that it's either not COVID-19 or there's a complication, a superinfection of this patient. So this is something you should be aware of.
Yeah, I do see this as a problem. Of course, now we're so highly aware of the disease that we might forget that we still have other diseases as well, which need to be differentiated. Maybe Lara and Baldo, maybe you can comment on that. How often do you have these problems, or is that nothing that you have to worry about at the moment in your situation because patients are tested and you only see the disease? What is your take here?
So we now we have these policies that we consider positive all the people come to the emergency department with the fever, cough, and flu symptoms. We do the throat swab, but many times the result negative. So we repeat after 24 or more hours, or doing the
yes, the deep bronchoalveolar lavage to be sure.
To be very sure, because the number of fast negative is very, very high.
And we fight. We are at the beginning of the epidemic. There were many CT scans of these patients. Now we prefer to do this type of exam in elected patients and doing other type of exams, in particular ultrasound, that can be one of the best tests to understand if there is a suspected pathology from COVID. Yeah.
I mean, yes, I think this is going to be one big topic we're going to cover here too, which is ultrasound, which of course has been always on my mind very strongly since we have our platform where we teach ultrasound. But it's also good to see that it is helpful in these situations. We'll come back to that.
And ultrasound is the way to go to monitor patients on the intensive care on a daily basis. And because we are going to see a number of cases afterwards, I was asked to give an introduction on what to see, on what to expect to see in ultrasound of the lung. So this is just a brief introduction. This is not a lengthy discussion on this topic, but so that you understand what you will see then afterwards in these cases. So just to remind you, what do you see on a chest ultrasound? Just here, this is an ultrasound of a healthy person. You see here the ribs, you see here the intercostal space, and you see here this hyperechoic line, and this hyperechoic line corresponds to the aerated lung. It's not the pleura itself, it's this border zone towards the aerated lung. The pleura itself is too thin to be visualized. And if you now look here, below that, you see these horizontal lines. These horizontal lines are either called A lines or window artifacts. In essence, these are just artifacts. You see here a reflection of these lines here. This is not corresponding to lung tissue. And if you look now at the moving lung, you will appreciate now that although the surface of the lung is pretty smooth, there are some irregularities leading to these lines radiating from the pleura towards the lung parenchyma, which is normal. Just a few of these lines are seen in each and every person, and these are called B lines. And then now moving on to a patient with interstitial pneumonia or diffuse alveolar damage, there's more edema now, more fluid in the lung parenchyma, and this leads to an increase in number of these B lines, as you see here in this patient. These are these lines radiating into the lung parenchyma. These are the so-called B lines you see in pulmonary edema, and you see it also here in this kind of infection. Importantly here, while in edema you see this starts bilaterally and the basis and creeps upwards, then in this disease, in COVID, you see more patchy areas of these B lines. So that's a characteristic that you don't see the distribution as evenly as in pulmonary edema. And then as the disease advances, and this is not a patient now with COVID, you see that the pleura becomes more irregular. You see then also some hypoechoic regions here, but this is according to the literature, the same effect you see then in COVID patients, that the pleura becomes more thickened and more irregular as an effect of the ongoing pathological process. And last but not least, you can also use then the ultrasound to monitor the ventilation. This is a patient, the same, that's a pig. That's one of our experiments we did a couple of years ago. You see here with PEEP 0, there's no ventilation going on. And if you increase here the PEEP to 15, you see that the lung parenchyma becomes ventilated. You see here the B lines indicating that the lung is ventilated. And last but not least, just look at, wait a second here, consolidations. In consolidations, the ultrasound waves may enter lung parenchyma, and you thus see not only the consolidated lung, that's this hypoechoic area here, but also within these small airways, you see the moving air. That's a positive air bronchogram in our terminology. So that's something to look for in patients with edema and in particular with pneumonia. So what are the findings in COVID? And that's my last slide. You see a thickening of the pleural line with pleural irregularities. These B lines are very characteristic, again, not specific. They are usually multifocal, but you have to see everything in a clinical context. You may see consolidations, and importantly, again, pleural effusions are uncommon. If you see that, consider differentials, superinfections, heart failure, whatsoever.
Yeah, thank you, Helmut. I think this is a very important lecture because I think lung ultrasound is definitely underutilized. It's such an easy and very, very good examination technique, especially considering that you have these small handheld devices. You can go into the intensive care unit. This is always a big advantage, especially in the situation where you have infections, where you don't want to bring in a big machine. Maybe Lara, Baldo, what is your experience here? I know you have some images to show as well, but maybe do you want to comment in general on how do you manage this whole situation with instrumentations, bronchoscopy? We have a question here coming also from how do you actually sterilize bronchoscope from Petra, and then there's been the question from Matthias, do you actually hook up two patients on one ventilator with a T? All of these questions are of course on the mind of some of your anesthesiological colleagues. Maybe you want to just summarize it briefly. What are some of the tips and tricks that you can give us when we might be confronted with a similar situation?
So use echo is easy because these patients are isolated in a part of our intensive care, so we can bring inside a lot of things. So use echo to see the different day by day. It's more easy with echo.
Okay. We can see that I have a story because maybe Lara today is very tired because this morning she has to fight bleeding from a tracheostomy of the COVID patients, a tracheostomy that was done a week ago. There was a lot of blood, and the surgeon that was trying to interrupt the bleeding. So when you have the bleeding in the airway, is a very bad situation, and the patient many times is prone to die. So lucky we passed this situation, and she was very clever. But when she went out, she was full of blood in their wearing, so, and the mask. So the fear is very high, and you have to fight this situation too when you are in an intensive care unit. It's not only the aspiration or the tracheostomy, but the complication of this procedure during a stay in the intensive care unit.
every time we do something on the lung, we turn off the ventilator because the spread is so high in this moment. And also when we do the bronchoscopy, we use filter between the ventilator and the bronchoscopy and the tube. So we try to protect in this way. And also we put on a the mask for the eye and use FFP3 when we are on this patient.
Yes, particular mask that try to interrupt the spreading of the spreading of the air into our airway. But it's we are trying because we have not a lot of experience. When you talked about the mortality in Italy, if you analyze the data of the first days in one, you see that the mortality was very high. But I think that we are learning. So during this learning curve, we are losing some patients because we are learning how to work in this situation that put us in danger. So when you go to the patient, you are not so quite safe, so you cannot work in like every day. This is the first, I think that you have to consider this aspect. We are learning which is the pathology, how to fight with this pathology. That is very new.
Yeah, it's of course for me.
From the past RDS that we see, it's very, very different. It's not the same.
We'll talk about that too, because this is also important, differential diagnosis. Bill, maybe you show us the case that you have, because I know you've collected some very, very interesting cases or figures.
I will show you how lung ultrasound can be of interest to do a differential diagnosis. We had last week a pregnant woman who presented to the emergency department with the hyperpyrexia, dyspnea, and the saturation on air, and we were worried about the COVID infection in these 30 weeks pregnant woman, and the suspicion was confirmed about the negative procalcitonin, the normal white blood cell count, the increase of the age. But when we performed in isolation and with lung ultrasound, we have seen how there was a normal A-line pattern in all the lung, and only small bibasilar consolidation with pleural effusion. We were not in a safe situation, but we can see how in this lung ultrasound, without performing a CT scan, can in part rule out a very dangerous pathology in a pregnant woman, in which you cannot perform X-rays or CT scan.
No question, ultrasound is really, really important here. We cannot overemphasize this, and I'm glad that you're mentioning this on so many occasions as well. This is your next slide, and I think you're going to show us something which is really, really a problem in the intensive care setting.
We are using a lot of devices to improve oxygenation in spontaneous breathing in this patient, above all non-invasive ventilation with mask or other devices. And in this, we can have many problems with the non-invasive ventilation, because when you use IPEEP, you can have subcutaneous emphysema, like this cause. In this case, this not happen in all patients, but it's only an image to let you understand that when you apply an IPEEP to an inflamed lung, you can do damage that is named auto-induced lung injury or ventilator-induced lung injury. So maybe, as suggested by many important authors in Italy, we have to prevent the secondary damage of the lung induced by IPEEP or pressure support. In particular, if you go to the next slide, you see a recent editorial of Gattinoni, who is the pioneer and our teacher of prone positioning ventilation, who said us that these patients does not have an ARDS. This is not an ARDS. So when we use IPEEP or prone positioning, we are not taking care about the lung, because we are fighting a lung with high compliance and with high level of shunt. So we are increasing oxygenation with IPEEP, but maybe we are going to do some damage to our lung. This is a topic to discuss. And above all, another way to improve oxygenation in our patient that is used in our intensive care when the condition of oxygenation is very bad is the prone positioning. And it's interesting to see that when you put a patient in prone positioning, you can have a recruitment of the dorsal part of the lung, of the basilar part of the lung. You can see in the ultrasound image down that there are micro consolidation of the pleural line, but you have an A-line pattern. But in the next slide, you see that when you put the patient in supine position, you have a de-recruitment part of the anterior part of the lung. So there are B lines on the anterior part. So you have a good oxygenation, but the edema maintains in the declived part of the lung. Okay, so maybe we have to understand which is the best way to ventilate the patient. And Gattinoni said us that in a condition with limited resources, the prone positioning for all patients can be a danger, because to maintain ventilation in prone positioning is very high research spending. So it's a topic to discuss to improve during the understanding of this pathology.
And so we have a lot of patients, and it's difficult to work with the protection on you. It's very hard. So it's difficult to for all the patients, the prone position. So it's very, very difficult also for us and for the nurse. So
you must choose who is the best patient to prone, and it's in this and the lung ultrasound can be useful to understand if prone positioning associated with low oxygenation in this patient. Maybe prone positioning is good. Maybe when you have quite good oxygenation, don't prone your patient in a limited condition of resources. And what we have seen, because we are particularly interested in the evaluation of the heart, that a lot of patients presented with right heart dysfunction that is independent from pulmonary hypertension. You see in these patients that had no anamnesis, previous history of heart disease, that presented after intubation, immediately after intubation. So the damage was not due to ventilation, with the right ventricular enlargement that with impact on hemodynamics, and that resolved with restoration after 24 hours of levosimendan infusion. This is very important because when you prone the patient, you have a right heart insufficiency, you will have an hemodynamic instability, and you can have cardiac arrest. So in my opinion, the evaluation of the right heart function is important before proning the patient. You must be safe about hemodynamic condition. Take care. And we had a cardiac arrest after prone position because we learned about this situation. Okay, when we did the Levosimendan, if you do the strain of the right heart function, the strain remains low. It seems that the right heart function recovered completely, but the strain remained low. And after 1 week, we had again, in the next slide, an enlargement of, please, the next slide. The enlargement of the right ventricle with the low pulmonary pressure that is not explained with right ventricular dysfunction, because you see the contractility is good, and this was the cause of a multi-organ failure and death in this patient. So in our opinion, the heart is one of the topic that must consider, one of the target of therapy that must be considered in this patient.
I think it's very, very important that, of course, it's a situation that the heart is always somehow involved. Of course, this is my area of expertise, and of course, echocardiography, I think, has probably a very important role. I have one question, which is probably one of the most frequently asked questions in the cardiology societies and groups, and that is, what about ACE inhibitors? You know, there's been a huge, massive discussion, and I would say creation of uncertainties among patients, because we know it's one of the most frequently used therapies together with angiotensin receptor blockers. We use them in heart failure, we use them in hypertensive patients, and there's now been some studies coming out, or some actually animal studies, which propose or maybe might suggest that there is some form of detrimental effects if patients take them. Have you seen this? Do you have any data, or what is your take on this?
But at this moment, we don't interrupt the medication. I don't know, because there are not certain answers about these problems, and because we don't have any evidence about this scientific evidence. If Jonathan can answer.
Jonathan, what is your take here?
Well, I would say that the European Society of Hypertension just on the 12th of March released information that should not stop the medication, and the same was released by European Society of Anesthesia. I think, from my point of view, that I agree with that. I think for the future we have to look more deep in that, and we should look more on the angiotensin receptor, especially to explain the infection, because while we were looking with my student Emily and Andrea about the literature and about the receptor, and actually there are angiotensin receptor all over the body, in the kidney, in the adipocytes, in the liver. And well, science is nice because there is disagreement, and I'm not on the side of cytokine storm. I think the cytokine storm is a consequence of viral infection. If you look, like most of the patients are asymptomatic or mild symptomatic because they have a airways infection of the high airways, and then if you are not able to solve the infection, it spread down. And I think there is a spread in all the tissues through the receptor of angiotensin. So for now, I say not interrupt the drugs, but we should carefully look into that to explain the disease.
Yeah, I mean, I think one thing we should be aware of that we're now confronted with, of course, a pandemic with the hospitals being completely blocked with patients who have COVID-19 infection. And we know that if we discontinue these medications, what can easily happen is that we have an exacerbation and an increase of patients with heart failure, and we would even provide even more burden to the healthcare system. And we know these treatments are highly effective. I would very, of course, be resistant to discontinuing this medication at this point before we don't have more data. It is at this point really purely speculative. We do not have the data at hand, and there are just, I would say, very preliminary data, and we know how it all is. We have to, of course, look at that. Again, I come back to this initiative that Jonathan is doing with bringing data together and getting this information. That will definitely help us. But I can only warn people that they should not panic and just stay on these drugs, stay on these medications. There is no evidence at this point. Yeah, I guess there's one more thing that you wanted to mention about the role of ultrasound, right?
Yeah, because when we had a patient in coma after COVID infection, and when you have to do a CT scan of the brain in this patient that is indicative of a stroke or other pathologies, and it's difficult. It's very difficult. And when you have a good temporal window, you can use ultrasound to do a differential diagnosis of hemorrhage in the brain. Maybe you don't have a very good image, but you can do a differential diagnosis with midline shift of the brain, or hernia, or hemorrhage. So I think that if you have a device that can do this job in your department, use it in this situation, because it's very important to monitor the patient and the cerebral flow too.
Okay, well, fantastic. Just one question that I'll pitch to you from the audience, and that is, do you see fatal myocarditis? Again, a question from cardiologist, I guess, and cytokine storm. I think we had one opinion here already that Jonathan mentioned that it's probably not the primary problem. What can you do to prevent this?
To prevent the myocarditis?
Yeah, prevent, of course, the infection of coming to a point where it gets that far. Is there any therapy or any things that you are using in your setting? I know there's antiviral drugs, and there's a lot of things that have been used for other diseases, but not specifically, of course, for the COVID-19 infection. Are you using any of these new therapies?
Yeah, of course, we are using hydroxychloroquine as suggested, and when we use the Redemsir, and then we use the Claretra, but now we switch to the Rolsta.
Okay.
But actually, it was published today on the New England Journal of Medicine, a paper on the antiviral drugs with no results, with no difference in the control versus the treated.
Yeah. I guess it's a very vain, of course, yeah. Good. I think we should slowly come to an end. I see there's many more questions. Like I mentioned, we don't have the time to answer all of them. Please, we have them now in our database, and we will try to answer them and put them on the platform doc-19. So please, of course, log in there, send some more questions, and look if you find your question there. And definitely, I think this is something that we want to push further and get more information on. I do want to thank very much, first of all the people who've been working on this. It was a tremendous effort on our side because we are now in a lockdown as well. It's very difficult for us to organize things. Our technical team, Giulio and Alex, and of course Robin, who's been here, and Stefan, they've done a tremendous job in organizing this through all difficulties, with difficulties in lines, and we usually do that in our studio setting, but here we're now almost in a little bit of a shack. Still, we try to make it as, of course, comfortable for you out there as well to see. I also want to thank the sponsors who've kicked in and helped us to support this, because obviously there's a financial need to produce something like that. And I can only also thank the speakers. Up front, very much our Italian guests. They're dear friends, long friends of the community. And I know again that this is something that is time for them that they could maybe spend with their families and relax, something they would need as well. But they're still so dedicated in treating patients, and you can again be assured that we have all the sympathy for you and all the support that we can give you. I'm sure we got so much from you during this webinar that will help us and maybe even save lives. And of course, I also want to thank Helmut. I do think that this information about lung ultrasound and CT is just of enormous importance, because it's a very simple tool, especially lung ultrasound, that will help us to make the diagnosis early. So again, thank you very much. Stick with us. Let's see if we can maybe put up and webinar again.
And thanks to Jonathan as well.
Yes, of course. Yes, I just meant the entire Italian crowd, of course. Yes, I do want to show a few things at the end because I think it's just important that you also see this too. I promised that, and that is the database that Jonathan put up. You've got the web address on the bottom. We can, of course, send it to you if you are interested, if you are working in an intensive care setting where you are seeing patients, where you are maybe also in a position to get your head of the department to contact Jonathan and to maybe take part in this initiative. It will be enormously important because that's where all the data should go together so that we find out what is really, really the problem in these patients, obviously to help others. So again. Thanks Baldo, thanks Lara, thanks Jonathan, thanks Helmut, and thanks to the team again, and hope to see you maybe soon on a webinar where we can give you information that I hope is important for you. Thank you again.